First of all, thank you, Karan, for making me part of this instruction course. So after we've learned about management of extraocular, that is the lid and the orbital trauma, we come to the ocular or the globe trauma, that is the management of corneal and the scleral tears. So it begins with proper history. So when, how, and where. And first and the foremost important is a detailed history of injury. So what is the mode of injury? How long has been this injury? Documenting the appropriate time, and what was the most probable object which caused the injury. So this gives a very valuable insight into the possibilities of any unsuspected or occult globe injury, posterior scleral rupture, presence of any intraocular foreign body, and presence of any concomitant microbial contamination which might have happened because of the trauma. So once you document the appropriate history, then we go to the proper preoperative evaluation, and we look out for the anatomical landmarks on the slit lamp very carefully, which include especially looking at the limbus, any stellate edges of the wound, the pigmentation lines on the epithelium due to any trauma or previous ocular pathology. And the very important is to look at the angles of the laceration which may be present. There might be any debris which we need to be removed during the procedure, and presence of any iris or vitreous strands which would be removed during the subsequent procedure. So once we have evaluated and we see that it's a simple full thickness wound, then if the wound size is more than 2 millimeters, there's no doubt we have to go and suture it, and there's a need for a definitive surgery. But if the wound size is less than 2 millimeters, then we need to look if the wound is self-sealed or not. That we come to know by performing the Seidels test using the fluorescent dye. And if it's a self-sealed wound and it doesn't leak even after performing a forced Seidel test, then we can leave it to heal by itself, or we can apply a bandage contact lens. But and we need to take appropriate precaution and need to go and suture it in especially mentally retarded or non-cooperative patients, or especially children who might rub the eye and lead to the wound leak later. In less than 2 millimeters, sometimes there might be stellate edges, or there might be a tissue loss. So, and it might be difficult to suture it. So we might need to perform a cyanoacrylate glue and apply a BCL to it. So once we have we understand that the definitive indication of a wound repair, that is a corneal or a scleral tear repair, we need to keep it in mind. What are our primary aims and what is our secondary aim? Our primary aim is to salvage the globe, and that would be by performing a procedure which will lead to watertight closure and structural integrity of the globe. And our secondary aim is to achieve a good curvature, avoid distortion, and so that there is minimal astigmatism, and at the end we achieve a good possible wood strength. So what are the suture materials we use for it? So preferably for cornea we use a 10-0 nylon or even a 9-0 nylon, and for sclera vicryl or braided silk is used. And we generally use a spatulated needle both for cornea and sclera rather than using round-bodied needles. So let's come to management of corneal tear repairs. So we need to understand certain principles for corneal suturing. So it has to be the minimal tissue handling, so as to just the needle touches the cornea, and as possible, and minimal grasping of the wounds so as to avoid the maceration and the cheese wiring. The entry has to be 0.5 millimeter away from the wound, and it has to enter perpendicular to the wound margin, and 90% of the depth of the tissue of the cornea has to be achieved, and so as to we have the epithelium to epithelium position, and preferably the spacing should be equal on both sides, unless there are vertical or shelved lacerations. So there comes the importance of the concept of zones of compression. So the zones of compression are uh, are formed due to the application of the suture. So it depends on the length of the suture. Here we can see, so this is the zone of compression, which is a kind of a rhomboid shaped. If we go and increase the size of the length of the suture, then the zone of the compression increases. And if the length of the suture is decreased, then the zone of compression reduces. So it is important to have overlapping between the zones of the compression between the two sutures, so as to avoid a wound leak. Here we see in the lower figure, the zone of the compression of the two sutures doesn't overlap, and there is a possible site of a wound leak, which might not be visible on this immediately intraoperatively because of the pre-existing corneal edema, but these wounds tend to leak later, and which might lead to shelling of the interchamber. So the compression factors depends on the area of the compression is dependent on the length of the loop, and it is preferable that smaller sutures should be applied in the visual axis, as longer sutures in the visual axis lead to greater tissue distortion and greater astigmatism. And this is a video of a simple corneal tear. There's very small videos just to have a look at it. So this is a very small. So this is a very small corneal tear, which is hardly 2 to 3 millimeter, and so it's hardly 2 to 3 millimeter in length, and the suture is directly passed with a no-touch technique, directly just even without the grasping the other end of the wound. And since the AC antechamber is pretty much formed in this thing, whenever the antechamber is not formed, we can form it using a viscoelastic substance, or even with air, if there is no leakage of the air. Okay. So I won't be discussing about the presence of any concomitant lens trauma or intraocular foreign body, because that would be discussed by the subsequent speakers. And at the end, the aim is to achieve a tight closure, and there should be no end leak at the end of the procedure. So next, we come to a case of a limbus to limbus corneal tear, in which the most important thing is to apply the first suture at the limbus, because this gives the best anatomical integrity, anatomical apposition, and then start the suturing. Oh shit, I'm sorry about that. Yeah. So first suture has to be always at the limbus, which gives a very good apposition, and then starts suturing in the center, and then divide it into different halves, and that's at the end of the procedure. So whenever we have a limbus to limbus tear, and which is pretty much straight, then we apply a technique called Rouse-Hayes technique, in which repair is started with longer sutures in the periphery, and the length decreases as we go to the visual axis, and then the corneal center is closed with smaller and widely placed sutures with minimal compression zone overlap. So this leads to the better contour of the cornea at the end of the procedure. So we often come across triangular flaps, in which the first suture has to be applied at the apex of the triangular flap, and then subsequently perpendicular sutures are applied to the edge of the wound. Rather, we need not to have parallel sutures as we have in case of straight wounds. So this is a case of triangular corneal tear, in which we can see the first suture is applied at the apex of the triangular tear, and then subsequently other sutures are applied towards the other sides of the triangle, and that's at the end of the procedure. its AC is pretty well formed and air leak is checked. The chances that we come across stellate wounds where there is a certain amount of tissue loss and we might need to put some bridging sutures and a use of a purse string sutures might be required in this case as seen in this image, and there might be a need of a combination of both bridging sutures and the purse string suture, and even after that, if the gaping is still there, that we need to apply a cyanoacrylate glue along with the bandage contact lens at the end of the procedure. Okay. So these are the purse string suture in which the suture is begun from one side. The needle is passed, and then we complete the circle, and this often seals the perforation in case of the stellate wounds. So coming to scleral tears, or which often have a corneo-scleral component. Similarly, the first suture has to be applied at the limbus. Can you look at it? Okay, so there's not much into scleral tears actually. The first thing is we need to apply the first suture at the sclera, at the limbus, and then start suturing the cornea, and then start the sclera. First, very important is to have the conjunctival peritomy to see the extent of the wound of the scleral component. Often we don't. Often it is seen that the end of the scleral tear is not seen because it goes pretty much posterior, and that leads to a hypotonia or the wound leakage later. So very important to expose and see what is the exact extent of the scleral tear. So it is a proper repair of the corneal and the scleral tear is not only globe salvaging and can prevent disastrous complications like endophthalmitis, but when done appropriately and meticulously, it can provide very useful vision and often restore near normal vision in select cases. So thank you. If any questions are there, I'll be happy to take.
I think one point I'll disagree on you, Anand, is that for perforations less than 2 millimeters, always I prefer that you should pass sutures whenever possible, because glue has its own problems, vascularization, then you have to handle it. So yes, glue is a very good option for tears when after suturing there's some sort of a wound leak or something. Sometimes when you don't have any tissue available and there is a lot of tissue loss, for the general ophthalmologist, what you can do is even after suturing, if there is a lot of gap and still the glue is not working, you can actually use a drape and put glue on it and stick it to the thing, and so it gives a good tamponading effect. Along with that, in such cases, it's very, very important to bury the sutures, and because you've had some tissue damage over here, the epithelium might have gone, so it's a good idea to put the BCL at the end of surgery as well.
Yeah, so the thing is, I get your point. You're saying that this glue I'm suggesting only in cases when there is a tissue loss. When in less than 2 millimeter size, if there is no wound leak, the Siedel's negative, then we can just leave it aside. But only in cases of tissue loss, when you know that suturing is not possible and it won't seal the wound, then I am suggesting that cyanoacrylate glue might be needed.
Agreed on that. Yeah.
What about Anand? What about corneal tear along with cataract? So do you do it in the primary sitting itself, or do the corneal tear and? Okay, Karan will take.
Yeah, actually I didn't touch that part, but certainly primary corneal tear repair is preferred, and then subsequently in the second sitting, the cataract would be preferred. I think Karan wouldn't be elaborating on that, but we might need to do the lens extraction when the AC is certainly very shallow and it is not forming at the end of the procedure, or there is certainly there's a lot of cortex in the antechamber. We might need to aspirate it, but would prefer in the second sitting that leads to better refractive outcomes and more predictability.
Okay, thank you very much. Nice talk.